I'm Julie Soukup with another episode of Take One Patient Podcast. I'm very excited to talk today with Melody Hartzler. She's a clinical pharmacist, and she also is the CEO of a very cool company called Pharm. I actually researched and found her a little bit when working with my dad, and actually kind of starting to see some different options outside of just pure medication for him. And I would love her first to really introduce herself, a little bit about her background, and kind of dive into what Pharm is, and kind of what makes it a little different.
Awesome. Well, thanks for having me. I'm excited to share about our process and what functional medicine is. So my name is Melody, like she mentioned. I also go by Dr. Hartzler in the clinical space, but I have my doctorate of pharmacy from Ohio Northern University, and I have done a residency postgraduate at the VA in Columbus, Ohio. And that was a clinical training program that was focused on outpatient care. So the VA has been really progressive with that. And so pharmacists are involved in primary care teams, renal care, home-based primary care, lots of other things. And so I took that, and over my career, over the last 12 or so years, I've been working in different family medicine practices, helping patients with chronic diseases, mostly diabetes. Also became a pump trainer. So I see patients via collaborative practice. So many states have collaborative practice agreements available for pharmacists to enter into with physicians or potentially nurse practitioners and PAs that allow us to adjust and make changes, start new therapies, monitor therapies. So Ohio has been pretty progressive with our ability to do that. So I work alongside the primary care team and function as a clinical specialist within that area as far as chronic disease. But over time, I have realized that a lot of chronic disease is not just, you're not deficient in a medication, right? Except with the exception, I guess, of type 1 diabetes as far as being deficient in insulin. But for the rest of the time, we're not deficient in Prozac or deficient in, statins or any of those things. Really, there's a lot of nutrition components to a lot of chronic disease. And so I started by just educating patients with diabetes about carb counting and the Mediterranean diet. And slowly through my own health journey, learned more about the relationship between gut health and the rest of the body as far as allergies and immune function. And then as I started to learn more about that, started to pull in the gut health connections to metabolic disease and started to incorporate that with my patients, and even nutrient depletions, how those impact your mental health and anxiety and depression and some of the inflammation components. And so it's all really connected. And so a functional medicine approach, which is what we do at Pharm. We're a group of clinical pharmacists that focus on addressing the root causes of these chronic conditions. As we do that, we look for the root cause. And so if someone has IBS, do they have IBS because they're missing a medication that slows down or speeds up their gut? No, it's because there is some kind of, whether it's an allergy or an inflammation response going on. It could be a bacterial imbalance, which is one of the most well-studied imbalances. So a lot of people with IBS, especially IBS-D, have what's called SIBO, or small intestinal bacterial overgrowth. Or maybe they have issues in the large intestine with overgrowth of bacteria. Or maybe candida or infections, fungal infections. So addressing the root cause of the infection fixes the symptoms. And sometimes it's stress related. We talk about, every single podcast we ever release, we talk about stress and how stress impacts our health from a chronic disease standpoint. It increases our cortisol. It decreases our digestive enzymes. We're not meant to be running from a bear for the rest of our life, right? Where, that response and that increased heart rate, decreased blood flow to your, parasympathetic, state, or that calming state, that is not meant to be all the time. And so with our psychological stressors and lots of the things going on in the modern day world, we end up being stressed more than we should be. And that impacts just so many different things in our health. And so I think, that aspect. So we use health coaches in that aspect to help people really identify what are the stressors. Sometimes we use, recommend psychologists or cognitive behavioral therapy or whatever that looks like. So that's a big key. Patients with past trauma, sometimes that is a block and why they're not getting well. And so that, again, we involve our whatever referral source we have in that person's community for cognitive behavioral therapy, and sometimes EMDR, which is eye movement desensitization reprocessing therapy. And so there's lots of different things beyond, what our traditional medical model is, where we just give drugs for, treating these chronic conditions. So nutrition, psych and psychospiritual, psychosocial things are really important. The gut health piece, and even just the nutrient depletion piece. So many medications actually cause nutrient depletions. And so every person with a statin should really be on CoQ10 alongside their statin, CoQ10 100 milligrams. But there's other nutrient depletions that are less common that can really play out in people. And sometimes it depends on their genetics and how long they've been taking the medication and what other medications that are depleting similar nutrients they're taking. And I know your clinicians that are listening to this have probably seen med list of patients that are 20 plus medications. And so when you add this nutrient is depleted slightly by this medication, it's not a big deal. But when you add 10 of those medications that deplete magnesium, then that can be a big deal for people. And magnesium is super important in the body. Iron is another thing. I mean, PPIs, there's millions of people on proton pump inhibitors, and it's changing the way we digest foods. It's changing the way we absorb iron. It's changing our microbiome. And so just thinking about those things from a different perspective, like how can we actually get rid of your heartburn by addressing it with a nutrition, dietary, gut, microbiome balance, and help people to get off these medications so they can absorb their nutrients the way that they should be.
Right. Well, and I think that was what was really cool about your company and the approach that you guys were going to is, you're really assigned to a pharmacist, who's going to be really saying, these are the things you're taking and these are the areas that you should be supplementing or looking more in your diet or counseling or whatever. And I thought, that kind of bigger, broader view as you're, saying functional medicine or not just giving a quick fix of a medication, but looking at really taking the time to look at a bigger picture of a patient to ensure that they're really, not like paying Peter to pay Paul or whatever, like with their own body.
Exactly. Yeah. So many people get put on medications because they have a side effect with one. So, okay, let's treat the side effect with this medication. And then this medication, it just snowballs into, they come in and I've had patients, dump a trash bag of things on the counter and say, I need all these refills. It's like, holy moly, like, how are you even walking like in here and driving and doing all these things when you're taking this many things? And so much of it, I mean, obviously the American way is we want a pill for every ill. We want to just get better quick. And unfortunately, like to really get better, it's not a quick process. It can be depending on how long someone's been sick, but it does require effort from the patient on exercise, nutrition planning, doing those stress reduction things, sleeping. I mean, that's a huge thing, is just getting sleep. And sometimes it's like, well, people are paying us to tell them you need to sleep more, you need to de-stress, you need to do these things. But sometimes they need help in figuring out like how they do that and how they implement that. But we have so much data on if you get less than 7 hours of sleep, you have increased risk for hypertension, metabolic disease. The list goes on. And so importance of, just getting that rest in this fast paced society where, we're burning candles at all ends, and I can be, one of those people sometimes.
Right.
You have to take a step back and say, this isn't worth it. And I need to take care of my body and get the sleep that it needs. And I mean, we have data on shift working that third shift, people have less longevity, decreased lifespan, and, hormone imbalances are super prevalent in that population. And so, I mean, some people have to work third shift. We have to have people at the hospital third shift. So, I mean, it's just part of it. But I think, supporting your body however you can in that process with the nutrition and decreasing stress is super important.
Sure. Well, and you kind of bring up a point, and I think it's interesting to think about is, taking one medication away that may not be working and giving weird side effects, but here's another and here's another. What do you think kind of is that culture? Not always, not all pharmacists, not all discharge nurses, but why do you think that is? Is it as far as like, let's prescribe something else? Do you think it's more of that we're learning more about like what is available outside of that? Or do you think it's a time constraint? Like, where do you think kind of that comes from? Or is it mostly a time constraint and that's the gap you guys are filling is, okay, we'll be discharged, but let us take the time to really help you model this after?
Yeah, I mean, I think part of it is a time constraint. So in the functional medicine model, with
48
Institute of
hours.
Functional Medicine talks a lot about this, is that, we have to hear the patient's story. And a lot of times that story, might take them like 45 minutes to tell me, like from birth to now, like what is going on? When was the last time you felt well? Did your parents get divorced and then you started having symptoms? Was there some kind of other trauma? Did you have a car accident? Like, what does that timeline look like for how this started to come to be? And certainly when you go to the ER or you go to the hospital or a family medicine primary care visit, you're getting 15 minutes to tell them what is wrong with you. They can't connect all those dots from the past in that 15 minutes. And it's very much okay, this is what we need to focus on today. Even if you have 20 things going on, you can only focus on so many in that 15-minute appointment. And ultimately the easiest thing for them to do is say, well, here's a medication, come back and tell me in 2 weeks if that works. And even at the discharge point, I think one of the challenges there is that the people that are caring for the patients in the hospital are not the people that are following up with them on the outpatient side. And like it used to be your family medicine provider would come and round to the hospital, write your orders, and you would, follow up with them later. And there's very few, there are still out there, but there's very few, primary care internists that actually round and do the outpatient care. And the specialty side, we see that more still, but on the primary care side, we don't, or internal medicine side, we see more of the hospitalist model where the hospitalists are caring for you in the hospital. And then your team over here is caring for you in the outpatient side. Certainly is better quality of life for those individuals, but for that continuity of care, it's a little bit challenging. And so I think when we're discharging, we're like, okay, this is, medically what is going to stabilize you and get you home, but it's not really thinking about and can maybe keep you from coming back. But it's not really thinking about like long-term, like, is this the best thing for your health? Is this the, most, beneficial, choice? And they don't have that relationship with the patient in that hospital in that short-term period to know, like, is that patient going to go home and drink, 2 gallons of Mountain Dew or 4 liters of Mountain Dew and come right back here if I don't give them this medication or this insulin or whatever the situation might be.
Right.
So I think that's one of the challenges is that they're not in a long-term relationship when you're in that hospital setting. I do think there's probably like the deprescribing piece at the med reconciliation, at the end is really important on that discharge is, okay, do we need this long-term? So I had a patient that I was trying to figure out why he was on a PPI. He had been on a PPI for like 10 years. I asked him, have you ever had heartburn? No, never had heartburn. Okay. Have you ever had a scope that showed, you had erosion or, Barrett's esophagus or anything like that? Nope, never had that. Okay. Looking back in records, nothing is leading to any of those things. So finally, I find that this patient started a PPI in a hospital admission when he was in the ICU for something else. And so it was basically his PPI for stress ulcer prophylaxis that now he got discharged on and took for 10 years before someone questioned it.
Wow.
So those are the kind of situations that when we're at that discharge point to say, hey, like, is this person have heartburn? Did they come in on this medication?
Yeah.
Do they need to leave on this medication? There's other simple things like people get discharged on a statin that's different than the one they have at home and they start taking both of them because the hospital formulary was different than their home formulary. I have my most recent practice that I was in, I was overseeing the transitions of care process from the family medicine side. So we would get the discharge summaries from the hospital and we would make the call within the 48 business day hours to help reconcile the meds. And so often, I think one of the other challenges is patients because they don't have that relationship, they don't have the trust with the hospital provider like they do with their family medicine provider. So half the time they're like, oh, I didn't do any of that stuff. I didn't do the stuff that the person at the hospital told me to do because I wanted to see what Dr. So-and-so here at your office thinks.
Yeah.
And so that's challenging, right? That the patient, we're like, hey, you need to do X, Y, Z, you need to pick up this prescription and, move forward. And they didn't even do it. So, and then sometimes that ends up with them back in the hospital on a readmission. Sometimes
100%. Yeah.
They're, not getting the prescription at the pharmacy because it's costing too much. And the communication from the pharmacy back to a hospital is much more difficult than the communication to an outpatient facility. So I think one of the biggest challenges in all of this is just that continuity of care between all those players that are part of the care team.
Right. Well, and as you said, I mean, even too, when you're getting discharged, that's fast, and the pace that is a necessity in the healthcare system to just be able to provide the amount of patient care that's needed for the amount of providers that are needed. I recognize that taking like, okay, let's take a step back and like, tell me about, they don't have
Right.
that.
No. And even in family medicine, they don't either.
Yeah. And it's interesting you say that, because you almost kind of, people typically, if you're going to be prescribed like, and I don't actually know anything, but like an antidepressant or anything, I don't know for sure, but I feel like you would have to talk to somebody before you're just handed, some of this medication. Yet some of the other things we're just handing, no problem, when they could be related to that other aspect. And I think that's one of the really cool things that you guys are kind of doing is looking at that whole piece to be like, the goal is to not just be popping pills forever. The other thing I think you hit really interesting on is, taking that step back. Like if we were going to give advice, like as we said, nobody has that 45 minutes, right? If we were going to give advice or communication advice to, a discharge nurse or a pharmacist or anyone that's kind of in that space where they're caught in a pattern where they're just go, 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 go. And they only have, the 3 to 5 minutes. What kind of would you suggest is even is most important? Is it taking a step back and really looking at it? Is it giving the patient resources to go to, or where do you see that as the communication aspect that could be improved?
Yeah. I mean, the best thing is really like the communication with the patient. I know a lot of times we get list and we reconcile the list from the pharmacy, or maybe from the family medicine office, and then the hospital, does their thing. But I find so often, at least in the hospitals around here, that there would be all kinds of medications on their discharge summary that the patient says they've never taken. They've never taken, or they weren't taking at the time. And so I think just spending the time with the patient, they're the best. I mean, I will say some patients aren't good historians and we have to rely on the list. They may not even be able to communicate with you. But if you can communicate with the patient, like trust what the patient says they're taking. And I think there's this, like, we don't want to take things off the list that like should be on there, but if the patient's not taking it, like it shouldn't be on their list, right? I mean, we can communicate in a different way to say, hey, like this was on your list, but they're saying they're not taking it. Make sure we pass on that information. But so often, I mean, there's just like old things. They were in the hospital for delivering a baby 10 years ago and they've got their meds still on there from that. And so, so I think making sure that we are doing a good job at really communicating with the patient when we can, and circling in, like one of the challenges with this environment of people going to multiple pharmacies is that they might get this med from this pharmacy and this med from this pharmacy and this med from this pharmacy. And sometimes we just contact one pharmacy to get a list. So the patient again can be that person that says, oh, I actually go to Meyer and Kroger and here because I get fuel points here and I get coupon here. So luckily the like gift cards for transferring from pharmacy to pharmacy have like calmed down a little bit. But I had a situation, a neighbor of mine when I was in residency went to the hospital. He ended up having rhabdo from a drug interaction, but it was because rhabdomyolysis, where muscle breakdown and causing kidney damage. But he had gotten a blood pressure medication called diltiazem from one doctor and a statin from another doctor, and filled them at separate pharmacies. But the statin was on like the $4 list. So it didn't hit the insurance to alert this other pharmacy that he had that combination. But that combination is what resulted in his hospitalization, because it was all this discombobulated, getting one thing here, getting another thing here, and people weren't, communicating. So I think from an outpatient perspective, like we always have to be asking patients every visit, and it's part of the process. But I think I've worked with a lot of nurses and LPNs and MAs over the years. A lot of times they'll just ask the questions, pharmacies too, technicians, do you have any medication changes? And patients might not even remember that oh yeah, I did have a medication. So they might say no. And I'm like, well, let me go through the list with you. You go through the list, and they actually did have like several things that were not correct on your list. So I think we just have to, remember that our job is to make sure this is accurate as possible. And it's not always going to be possible because there's, a lot of things outside of our control, and we don't have one master system for everything. But the most, important thing is to like go through all the medications, not just say, hey, are you still taking lisinopril, but are you taking lisinopril 10 milligrams once a day, and make sure that, that whole prescription is correct. I see the hospitals again around here a lot that will have a different strength and then say like 2 tablets instead of 1 tablet, but the patient isn't really taking it like that. And so that can be confusing, just how it got selected in the system. So just going through in detail with the patient, I think will identify a lot of things. And I don't know how each person's discharge process is structured. Do they have time to talk to the patient? Hopefully, if they're doing discharge counseling. But I think even at the forefront in the ER, doing a better job about figuring that out with the patient is really helpful. So if places aren't engaging the pharmacy team for the ER portion and are just doing it on the back end, maybe starting to engage the pharmacist in the ER for MedRec or a part of the pharmacy team. Some hospitals will use pharmacy interns to do that. Some hospitals will use pharmacy technicians that have been trained in medication reconciliation. So doing it from the whole, whole loop there.
Yeah. And it's interesting you say that too, because even like clarifying and getting more information and clearing that up and clarifying the medication could be even done originally, even kind of by a nurse. If you're asking questions, you're trying to kind of clarify it. And it's interesting you say that because, Medical Memory just partnered with one of our hospitals where they're so strapped on the pharmacy, and he actually started sending video messages using our app to the patients about things once we have the information. He's like, I can't go, but I feel like I still need to have that conversation. Going room to room to room was super hard. But so he would sit, like, look at the medications and then have almost like a 2-3 minute video conversation.
That's great.
The patient could watch it when they got home. But it almost, he's like, not going room to room to room gave me an extra 2 minutes to educate. Hey, there are different options like what you have, or nutrition options, or things that you should look at in conjunction with that. And so starting to use some of the, tech to either, send that information via like, here's it custom, or even like videos of like, hey, this is a general information that you should know about taking cardiovascular medication. Here's all the risk benefits and all that, which a few of our pharmacists have even started doing, so that at least the patient can go home and say, okay, I need to do a little more digging. And here's resources like your company that are out there that can do it. And you guys do that a ton in your podcast of, here's, I'm even looking at it. It's like, foundation of health, nutrition, of sleep, of movement, of stress, and all of those things that could provide a lot of mediums to maybe either minimize or get off some of the medications that they're on.
Yeah. Ultimately what we're trying to do from a functional medicine standpoint is support like the biochemistry of the body and how the body is supposed to function. So if we have too much of something or too little of something, like that's throwing off the balance, which is one of the reasons why pharmacists have a little bit of an advantage in this space, is because we've done a lot more biochemistry in our background than a lot of other healthcare professionals. Also from the supplement standpoint, like pharmacology is similar to how, it's all how does this interact with receptors and produce an effect. Deep diving into supplement interactions too is we have more limited data on how supplements interact with medications, but definitely spent a little bit more time talking about resources for that than some of the other healthcare professional groups.
Awesome. Well, you've been so informative. And I think even what you're saying is for anyone who's kind of falling in the same communication pattern with patients is taking that step back, have a nurse take a step back to just really look at it. And even just vocalizing, hey, there's a ton of resources that are out there that you should look at, to kind of see different ways of managing this whole piece versus just managing this one prescription. So thank you so much.
Yeah, thanks for having me. I appreciate it.
Pharm to Table is what it's called. It's awesome.
Yes.
Check out their
Pharm.
Pharm. Yes, Pharm. That's why I said Pharm. I should. And
yes, pharm.life. L-I-S-E. Yep.
Okay, yeah, farm2table.life is what it is. And I can kind of I'll put
Yep. And the
something
link to
out
our
too.
podcast. Our podcast is called Table Talk, but a link to our podcast is on the page as well.
Awesome. Thank you so much for your
Yeah,
time.
thank
I so
you.
appreciate you. And we'll talk to you, I'm sure, soon.
Okay, thanks.